Hi, this is Lindsay Luther, one of your professors in your Nursing 570 Primary Care 1 course. I wanted to start this week's lecture because it's the first week of the semester by giving you a quick overview of how to be successful using these lectures in our course and what to expect for using them. So the first thing that I wanted to do is actually show you one way that you can make your life easier in this course. I know many of you had Bev Gish for pathophysiology, and similarly to the way that she does her presentations, I will do my presentations by putting notes in this bottom section of the PowerPoint slides, and these are going to be available to you as PowerPoint slides. Additionally, I wanted to show you a way that you can print the slides and the notes side by side so that when you're studying, you can have those comments next to that and you don't have to rewrite everything. So in order to do this, you can select the File button. You have to be on a non-Mac computer, so you have to be on a PC in order to do this. I don't think that the Mac option for PowerPoint allows you to do this, but I think probably I can either post the notes pages or your classmates could get them for you, or you can use one of our computers on campus in order to print them. So in order to do this, you are gonna, and you can actually continue while you're listening to these PowerPoints to take notes in this area, and then wait to do this until afterward, but you're going to go to File. You can select Save and Send, and then you can select Create Handouts. When you hit Create Handouts, choose this option that says Notes Next to Slides. You can also choose Notes Below Slides, but I think this one works a little bit better. And then hit OK. This is going to open a Microsoft Office page, which is going to fill in the slides next to the notes. From here, you can highlight and change the size of these notes pages, and this will allow, the size of the text of the notes. You can also change the margin sizes to make the slides bigger or smaller. You can even get rid of this column if you choose to, and all of that will give you options for how to print these efficiently. So I'm going to go ahead and close this, and we'll get started with week 1. Okay, so let's go back to the beginning. Okay, so I did want to just warn you that many of the graphics in this presentation have been reproduced with permission from UpToDate, so they are subject to copyright and licensing agreements. We're going to start. The purpose of this whole presentation is to review the basic physiology of female puberty, and this provides a context for understanding contraception, pregnancy, fertility, and then also the pathologic and gynecologic conditions that you will be diagnosing in practice. The recorded portion of the lecture is going to hone in on the key areas that I want to focus your attention. Today's lecture in particular will be longer than some of the other ones, and the reason for that is that I really want to make sure that you understand these basics, because this is really the nuts and bolts that will create a scaffolding for you to be able to understand the rest of the material this week as well as all of the material next week. It's important that you still read all of the material that's included in the slides and in those note sections. And remember to write down any questions that you have. You can either bring them to class when you come on Wednesday, or you can post them to the 24/7 office hours discussion board if you'd like a response either after class or in a more timely manner. And then if you're not familiar with, if you have any concerns about the presentation, please contact me. So we're going to get started first with an overview of female reproductive physiology. So the first thing I want to point out is that there are several terms that are used to describe puberty, and these include puberty, gonadarchy, adrenarchy, thelarchy, pubarchy, and menarchy. If any of these terms are not familiar to you, or if you can't immediately pull them out of your head, then please go ahead and review this slide. In the United States, puberty typically begins between the ages of 8 and 13. There is some variation in the onset of puberty by race and ethnic background, and we'll talk about that shortly. In females, the process of puberty will begin with breast development, and this occurs because estradiol is released from maturing ovaries. Those ovaries are maturing in response to stimulation from pituitary hormones, so LH and FSH. The appearance of pubic hair, axillary hair, and the production of apocrine, sweat, and body odor will occur because of androgen release from the adrenal glands. The first menstrual period typically occurs due to stimulation of the endometrial lining by estradiol, and then after maturity of the ovaries, which takes about a year, the ovulatory cycles are perpetuated by the interplay of estradiol and progesterone in the uterus. All right. So again, puberty starts with that pulsatile secretion of GnRH by the hypothalamus, and this stimulates LH and FSH. And then these will stimulate the gonads, so it's that same feedback loop that we've heard about before. Estradiol is the primary estrogen that's produced, and this leads to breast development, skeletal development, and the fusion of growth plates, as well as ovulation and menstruation. The growth spurt associated with puberty starts a couple of years earlier in girls than in boys, and it's responsible for nearly 20% of the adult height. One of the funny things about puberty is that the arms and legs in females tend to grow first, and then the axial skeleton follows. That growth spurt lasts about 2 years in both sexes, and one of the things that is unfortunate is that the bone growth happens faster than bone mineralization, and this means that an adolescent that's going through puberty is especially vulnerable to fractures. During puberty, about half of the total bone calcium will be deposited in females, and then at this age there's also some variation in ethnic groups as far as the amount of mineral deposition. So we know certain populations are more likely to have osteoporosis or osteopenia, and that starts even in puberty. We can see those differences. And so we have to also monitor females in the adolescent period for excessive fat distribution, because this is a risk factor for continuance into adulthood and may preempt future obesity and cardiovascular morbidity and mortality. Okay. Pubarc is usually, so THLARC, or the development of breasts in females, is the typical first, I'm not sure what happened there. So THLARC is the typical first sign of puberty in most females, although development of pubic hair can be a sign of puberty in others, particularly in African American females. Those who have pubarc as the first sign are also more likely to have been born to a mother who had preeclampsia, and these females tend to maintain a lower BMI throughout puberty. The earlier the age of menarche, so especially before the age of 12, the higher the risk of increased BMI throughout puberty and adolescence, and adulthood, and this is likely mediated by childhood obesity. So children who are obese are more likely to go through puberty sooner, and then they are more likely as adults to maintain that high BMI. There is a good amount of literature and well-conducted literature that has demonstrated that there are differences in the age of puberty for different populations. African American females have a particularly early maturation compared to white females, and that's almost a 2-year difference in some cases. It's normal for that whitish vaginal discharge to start beginning about 1.5 to 2 years after the onset of puberty, and it usually starts about 6 months prior to menarche. So if a girl is complaining or talking about that, that's a good sign that they're progressing towards menarche, and you can give her some anticipatory guidance that her period's probably going to start within the next 6 months. And then the time span between the first sign of puberty and the onset of menses is usually between 2.5 years. So that's another way that you can warn families and especially young women. The Tanner stages are used in clinical practice to describe the adolescent's progression through puberty. So in females, we describe both the breast development and the pubic hair development. Typically, these stages go together, so stage one in breast development will go with stage 1 in pubic hair development. Sometimes they don't exactly match up, and that's okay, but it is typically they go pretty well together. All right, so this shows the sequence of puberty in girls, and I'll let you look at this. It does show that the median ages for these different events in Caucasian girls tends to be later than the median age for African American girls. There are a lot of common disorders that are associated with adolescence. Iron deficiency anemia affects a large number of adolescent females. About 9% of adolescent girls will have a deficiency in iron, and 2% of these will be anemic. And this is likely due to both a combination of not enough iron intake and then a loss from menstrual bleeding. Acne in puberty is associated with high androgenic stimulation of the follicles of the face, and this causes inflammation and obstruction of those follicles. Depression is actually considered twice as common in adolescent girls than it is in adolescent boys, and it is associated with a reduced satisfaction in the self and with physical appearance. White females actually show a higher rate of depression than others. Those who have early onset and late onset puberty are also more likely to be depressed. We get concerned about these things because there's also an association with social risk factors in early puberty, and this includes having older friends and risk-taking behavior. So that's a correlation that you just want to think about when you're thinking about these young children or young adults. Children in this age group are particularly vulnerable to musculoskeletal injuries and epiphyseal growth plate injuries because they're growing quickly and their bones are not mineralizing properly. They get a little bit awkward, and this can lead to abnormal range of motion of certain joints, especially because, as I said before, the arms and legs grow more quickly than the axial skeleton. There's also a high incidence of Osgood-Schlatter disease, which causes inflammation of the tibial tubercle apophysis, and so this is something we see a lot in especially athletes in their adolescent ages. This is also a time when abnormal uterine bleeding occurs, and this is defined as excessive, prolonged, or irregular menstruation. This is usually caused by anovulatory cycles. As I told you before, it's common for cycles to be anovulatory for at least that first year. There's a change in the growth of the eye, and this can lead to nearsightedness in puberty. Scoliosis or S-shaped curvature of the spine can occur. And then there's also a high risk of sexually transmitted infections, and this is likely due to both behavioral and biologic susceptibilities associated with puberty. The cervix is not fully developed for those first 1 to 2 years after the onset of menses, and this can make the female adolescent more susceptible to chlamydia and HIV. Okay, so the next thing we're going to look at is the menstrual cycle. It is incredibly important that you understand how the menstrual cycle works. I understand that it's not, it can be a little bit confusing, but understanding this will give you a huge leg up on identifying both normal and abnormal gynecologic conditions. In most women, cycles will last between 28 and 35 days. This is 28 and 35 days, yes. And adolescents can have a normal cycle that lasts up to 45 days. Eventually, that should shorten down to the 28 to 35 day cycle. There are 2 phases of the menstrual cycle, and these are the follicular phase, which starts with the day of menses, so the very first day of the period is considered the first day of the cycle, and then that continues for 14 to 21 days and ends on the day prior to the LH surge. The LH surge signifies the beginning of the luteal phase, which is the second half of the menstrual cycle from ovulation until the next menses, and then that luteal phase will end the day before that next menses starts. Throughout the ages of 20 to 40, your cycle tends to be consistent, but then it will shorten after the age of 40. And then variation in cycle length. So if a woman's cycle varies between, if cycles are 28 days versus 35 days, that usually has to do with how many days the follicular phase is rather than the luteal phase. The time between ovulation and the next menses is almost always 14 days, give or take a couple. Adolescents, again, have cycles up to 45 days. This gets normal within 2 to 3 years. So we just talked about how the menstrual cycle starts with the starts with the follicular phase. This graphic can be a little bit confusing because of that, because they have marked day 0 as the LH surge. So I want to just point out that the follicular phase in this diagram is starting right here on -14 and is lasting until day 0, and then day 0 is the LH surge in the beginning of the luteal phase. This shows how the FSH levels and the LH levels are moving throughout the cycle. You can see that in the first graphic, the LH surge is marked as day 0. The mid-follicular phase, so the early follicular phase is the most hormonally quiet part of the menstrual cycle. There's little physiologic change in the ovary during that time. The mid-follicular phase, so right in here, is stimulated by a slightly elevated FSH level, and this induces development of the ovarian follicle as well as estradiol production. Estradiol allows for the growth of a group of follicles, and this further produces estradiol, which creates then a negative feedback response in that HP axis that ends up suppressing the FSH and the LH. Several follicles can be present on ultrasonography during the mid-follicular phase, but the late follicular phase is characterized by continually increasing estradiol until the peak level on the day before ovulation. Typically, only one of those follicles will be released during ovulation, although more than one follicle, can be released, and in that case, there is a potential for fraternal twins. A subsequent positive feedback response will occur after the late follicular phase, and this results in a surge of LH, which makes the LH rise to about 10 times the prior concentration. It's not really understood why this occurs, but this marks the beginning of the luteal phase. The LH surge causes the oocyte in that dominant follicle to complete its first meiotic division, and then that oocyte is released from the follicle about 36 hours after the LH surge, and it travels down the fallopian tube. Because this LH surge occurs just before ovulation, it can be used as a predictor of ovulation in women with normal ovulatory cycles. The follicle, even prior to rupture, produces a large amount of progesterone, and this slows the frequency of those LH pulses and causes that LH to drop down. The endometrium becomes less differentiated, which means that you lose that triple stripe appearance on an ultrasound. You can see here that the beginning of that luteal phase occurs with a steep drop in estrogen and increased levels of progesterone, and that supports the development of the endometrium. The endometrium is where that fertilized egg will implant in the case of pregnancy. So as the luteal phase progresses, less and less estradiol and more progesterone are produced by the corpus luteum in the absence of fertilization. If the egg is fertilized, that fertilized egg will implant within the endometrium within the 7 to 14 day period after ovulation. And this embryo will then begin producing chorionic gonadotropin, and that hormone maintains that corpus luteum and produces additional progesterone. In the absence of fertilization or implantation, that resolving corpus luteum will produce less and less hormones, and eventually that reduces the blood supply to the endometrium, which causes endometrial sloughing and eventually the onset of menses about 14 days after that LH surge. As the corpus luteum stops producing steroids, that HP axis comes out of that negative feedback loop, and then the FSH levels start again. So this 14 day right here is actually the same as the beginning of this day right here, and same here. So that day 14 here at the end of this cycle is the same as the beginning of the next cycle. So really this is a continuous loop. Okay, so another way of looking at this is to look at the hormone levels that we just talked about. So here we have FSH, which is the green, and the LH moving through the cycle. Then you can see the coordinating changes in estrogen and progesterone. You can see that the endometrium is reacting to those different levels, so building as the progesterone builds. And then you can see that the body temperature is also pretty similarly responsive in the same way that this is the core body temperature. It's pretty similar to what the hormone levels do and what the endometrium does. And then also the ovarian cycle, the way that it changes throughout. This understanding of body temperature is important, as well as understanding of this LH surge when you're talking about some of the manners of monitoring fertility, and we use basal body temperature to predict when ovulation has occurred, because you can see a sharp, if you know your basal body temperature, you can see then when that rise occurs. We also do some LH testing to predict when a woman is about to ovulate. So if you see that ovulation is occurring here, that LH spike happens just before, and then you can confirm ovulation with a temperature rise on the day after. Okay, so that is the menstrual cycle in a nutshell. We're not going to go into menopause as deeply, but I do want you to understand that this is the permanent cessation of menses greater than a year. So one of the things that women find funny, and this is one of those funny definitions in clinical practice, menopause really only lasts for one day, and that up until a woman has not had a period for a year, the woman is premenopausal. The day that the patient has had no period for 1 year, the patient is menopausal, and then the day after that, they're considered postmenopausal. So this normally occurs around the age of 51 and a half, but it's considered within normal ranges to happen anywhere between 40 and 55. However, if a woman is 40 to 45, she should be considered for other causes of amenorrhea in addition to just perimenopausal state. And then if bleeding is still occurring after the age of 55, that's when we would like to do a hormone workup to make sure that the woman does not have postmenopausal bleeding, which can indicate either a endometrial cancer or a progression towards endometrial cancer. So in this stage of menopause, the FSH level will be consistently over 30. For women who are on birth control in menopause, we typically withdraw that birth control around age 50 and then check hormones about 2 to 4 weeks after to make sure that FSH level is where it needs to be. So perimenopause is that phase heading towards menopause, and it usually lasts about 4 years. Cycles will change in length from between 25 to 35 days to 40 to 50 days. The FSH levels will be higher than normal, but how high is variable. Cycle irregularity will continue to increase. The duration and atypical nature of bleeding patterns will continue. There will be some anovulatory cycles, and there may be periods of time where there's no menses at all, less than 1 year. And those FSH and estradiol levels will be up and down all over the place. Most women will eventually have less bleeding amounts over time, but some women will have heavy or prolonged bleeding. There is a system that can be used called the straw system, which can stage progression towards menopause. I do want to point out that the hormonal fluctuations that are a normal part of the perimenopausal period cause symptoms which we often consider to be dysfunctional. However, they are actually physiologically normal given the processes that are occurring. That does not mean that they are not uncomfortable and don't need to be treated, but we also need to make sure that women understand that what they're experiencing is normal. So these are, this is one of the methods for staging menopause, and it talks about the reproductive system and that transition into menopause and postmenopause, and how we look at hormones during that level or during those different phases, and how we might see symptoms occurring. So menopausal symptoms, typically women complain of hot flashes and night sweats the most. Hot flashes are basically a sudden sensation of heat that starts in the upper chest and face and spreads throughout the body over a couple of minutes. And this can happen anywhere from 2 to 24 times a day, usually overnight, and so it can be very disruptive to sleep. And then we typically try to treat this first with behavioral modification. So teaching women to dress in layers, lower external temperatures, so turn up those thermostats for the AC, avoid heat, and avoid other triggers like spicy foods. I did provide a link in the notes on this slide for information on hormone replacement therapy, and I would suggest that you look into that because it's something that you will probably see at some point, especially in family practice. Other menopausal symptoms that can be disruptive but are not necessarily unexpected include alterations to sleep, mood, the vulvovaginal atrophy, so the tissue texture, and there may also be a little bit of declining condition, although this tends to be kind of mediated through other things like anxiety and depression and sleeplessness. And then there's actually a fair amount of joint pain, so that's something to be aware of. We worry particularly in this population about bone loss and cardiovascular disease. So let's talk quickly through the annual exam for women. Okay, so when you're doing a history and physical, you basically want to get to anything that might affect their current health, social health, all of the normal components. Some things that you would add to this include screenings and health promotions like their most recent mammograms and pap testing, whether they do self-breast exams. You want to pay particular attention to cancers that have inheritance patterns, so breast, colon, uterine, ovarian. You want to get a good menstrual history, childbearing history, history of sexual activity, and you want to make sure that you're doing a good overview of their safety, whether that is interpersonal safety or just habits of day-to-day life. You also want to make sure that you're addressing those common concerns that can occur alongside of, that can occur when you have, when you have a uterus, when you have a vagina. Any of these things can occur when you are a woman, so we want to just make sure we're identifying and addressing them. The physical exam in a women's health visit is sensitive, and you need to make sure that you're taking care of the patient's comfort and privacy. When you're trying to decide which systems you should assess, you want to think about the rationale for including or omitting any body system. So for example, it's almost always appropriate to listen to heart and lung sounds. You may not, however, feel that it's necessary to palpate the precordium or feel for tactile fremitus if there's no complaints that support that. And before you start the exam, you should have a plan of action for what assessments are going to help you to get information related to the patient's chief complaint or their general wellness. Before you start the physical exam, you should always ask the patient if she would prefer to have the people who accompanied her to the visit stay in the room or if she would prefer that they leave. You want to give her an opportunity to remove clothing in private if possible. You should consider having a chaperone regardless of whether or not the patient asks for one. It protects you as well as the patient. And then you should offer the patient opportunities to verify consent for each portion of the exams. And this is especially important for women who have a history of sexual assault, which the patient may or may not have told you about. So you can then progress from, as usual, from head to toe, start with vital signs, go through the remainder of the body systems as indicated. You want to assess the breast, genitalia, internal organs, etc., using that same pattern of inspection, palpation, percussion, and auscultation as appropriate to that system. Okay, so note about cervical cancer screening. So keep in mind that pelvic exams and cervical cancer screening or pap smears are not synonymous. We do pelvic exams at pretty much every annual exam independently of the cervical cancer screening. So the more we screen people, the more likely we are to find something that requires additional investigation. So the USPSTF and ACOG and many of these other organizations have discussed, have made recommendations as far as who should be screened for cervical cancer. I want you to take this information right here and memorize it right now. This is absolutely what you are going to be tested on your boards and also in this class. You need to be able to reproduce this information as far as screening. Keep in mind that high-risk HPV strains are the most common causes of cervical cancer and genital warts. These 4 strains are included in the HPV vaccine. And so you can now offer that HPV vaccine to anyone up to the age of 45 if they have not been vaccinated. You can consider offering the vaccine in other situations based upon clinical judgment and the preferences of the patient. STI screening should occur in any patient between the ages of 13 and 64. HIV screening in particularly should be tested if the local prevalence is over 0.1%. You can offer patients the opportunity to opt out. It used to be that we required written consent and that we had to have patients opt into screening, but now we're allowed to have them opt out, which means that you can screen them unless they tell you you cannot. You should consider screening high-risk patients yearly. So there are some specifically pregnant women, tuberculosis positive patients, and those who have other STI treatment. Recommendations for STI screening include checking chlamydia and gonorrhea in sexually active females under 25 and over the age of 25 yearly if there are new partners. You should also check anybody who has symptoms. If a woman is born between the age of 1945 and 1965, she should be screened for hepatitis C. So breast cancer screening, there are a lot of different guidelines available. We do know that breast cancer screening elicits false positives, and especially in younger women, and this can lead to additional unnecessary testing, which can be expensive and traumatic. So there is not a lot of good evidence that screening mammograms, so asymptomatic patients with no concerns before the age of 50, saves lives. So different organizations will recommend different things, and again, I've listed this here. I think the ones that I've included on this slide are succinct enough that this is not a bad thing to memorize. So the USPSTF tends to be a little bit more conservative, or tends to be a little bit less likely to screen for things. So they recommend that you should start by 50 and offer every 1 to 2 years if the patient has average risk. And that's the average risk versus high risk is defined here. If the American College of Physicians recommends optional mammograms starting at age 40 for high risk, and ACOG recommends offering mammograms at age 40 using shared decision making, but then definitely by 50. And then that screening should continue every 2 years for women with a life expectancy of more than 10 years, according to the American College of Physicians, or at least until age 75, and then on an individualized basis by patient health status, and that's an ACOG recommendation. So you can see that they all kind of have their 2 cents about this, and that's something that you're going to see a lot in practice. When you're choosing which clinical guidelines you're going to use, you want to make sure that, first of all, the guideline matches your patient population. So whatever they studied in order to develop the guideline, your patient should fit the people included in that study. The other thing that you want to consider is that specialist groups tend to be more inclusive in terms of screening. They want more people screened, but more public health agencies like the USPSTF consider other things like availability of resources and financial issues, and so they are less likely to offer screening on their perception of risk and benefits. Okay, so the last thing you need to be aware of in that women's health visit is osteoporosis screening. Any woman over the 65 should be screened with a DEXA scan, which measures bone mineral density. You can consider a risk calculator. So these are some of the tools, and these are active links, so you can click those and open them and try out those tools. You should consider screening any woman under the age of 65 if she has risk factors. Those risk factors include a prior fragility factor in the patient herself or in a first-degree relative like a mother, sister, father. If the woman is a woman, age over 65, or an estrogen or testosterone deficiency, and again, that's a physiologic deficiency, so if they have documented low hormones as a result of their age and menstrual status. Okay, so that concludes this first part 1. Again, if you have any questions, please post them to the discussion board or write them down and bring them to class. There will be 2 other small lectures which will provide more of a key concepts, and then you can read the lectures to pick up on the areas that you're not as familiar with. That'll include contraception and some of the disorders and fertility and many of those things. I always will list my references for you here on the slide, and so if you want to go find some of these resources and do some more reading, you are always welcome to do that. So there's a couple on these 2 slides. Thank you so much for listening, and we will see you this week.